This is Dr. Sumeet Mhaskar. I'm a urologist, and I'm sharing this video to just for information about prostate or benign prostatic hypertrophy. Now, prostate basically is an organ in the male human body. It is not there in the females, and basically it's a sex organ. But however, the urine passage from the bladder to the urethra passes through the prostate, and hence it creates a physiological importance of this prostate organ. If you see the genitourinary tract of the male urethra from the bladder, it originates from the bladder, passes through the prostate, where it is joined from the seminal vesicles and the testicular vas deferens uh, to form the ejaculated duct, and then from that area, from the junction, the urethra becomes a common pathway for the sexual and the, hello.
સાહેબ પેલું રિમાઇન્ડ માટે કોલ કર્યો પછી
અરે ચાલુ છે તું જોતા નથી. That the male urethra passes through the prostate, and hence it's important. Now, what is the prostate? A prostate is a small walnut-sized organ, which is a part of the male sexual system. It is not a part of the urinary system as such. It produces a fluid which forms a part of the semen. So, the prostate gland, like I showed, it is at the base of the bladder where the sexual and the urinary pathways combine to form a common pathway through the penis. So now what is BPH or benign prostatic hypertrophy? It's a non-cancerous benign growth of the prostate. It's an aging process of the male. Basically, it happens in every male alive. So it is not a disease as such. I don't consider BPH as a disease. It's a part and parcel of a aging process. And if you age to cross a limit, a certain age, around 40, 50, 60, 70, you're going to have BPH. The main cause of this is the male hormone, testosterone, which is converted to dihydrotestosterone, is the active ingredient of that testosterone. And this is where the dihydrotestosterone acts on the prostatic glands to help it proliferate. So after the age of 40, the prostate grows bigger due to the increase in this hormone, because there is proliferation of the uh, prostatic glands. So like that, the hypothalamus and the uh, uh, release the LHRH or hormone, which acts on the pituitary to release the LH and FSH, which acts on the testis to increase the testosterone levels, which acts on the alpha reductase 1 and alpha reductase 2 inhibitors, which releases dihydrotestosterone, basically it activates dihydrotestosterone, and this causes proliferation. So if we give a 5 alpha reductase inhibitors, they will inhibit the 5 alpha 1 and 2 inhibitors, and hence causes decrease in active testosterone, and hence can cause decrease in the size of the prostate, which we'll come to later. So this is how the testosterone works. This is the same thing. The testosterone is converted to dihydro in presence of alpha reductase enzyme, and it binds to cytoplasm, where it releases nucleus, binds to DNA sites, and helps in proliferation of the cells. So this is what normally happens. Okay? When the DHT is active, it causes cell proliferation. When the DHT is negated or blocked, it causes cell death. And this principle is used when we give 5 alpha reductase inhibitors in BPH in a particular group of patients. Now, to understand the causative factor, we have to understand what basically, now we know there is a prostatic gland which has a receptor stromal centers and a muscular center. And these muscular fibers have adrenoreceptor receptors, alpha and beta. Basically, alpha 1 is more concentrated in the bladder neck and bladder neck and the prostatic tissue, and that is where the selective alpha 1 inhibitors, or you can inhibit the whole alpha. The earlier alpha blockers was a broad spectrum alpha blockers which inhibited the whole thing, while uh, the samsulosine is a selective alpha 1a inhibitor which selects only one thing and blocks it. Beta blockers are totally different and they are useful for blood pressure management. So if you see the distribution of alpha receptors in the prostate, it is more in the trigon and the bladder neck area and the prostatic tissue area. The overactivity of these causes the spasm of the smooth muscles, increased tone of the smooth muscles, and this puts pressure on the urethra to cause obstruction to the urinary flow. This mechanism is inhibited by alpha blockers when we give for a treatment for BPH. So what happens in BPH? As the prostate enlarges, there is a stromal component which enlarges. Also, the adrenergic tone of the muscles in the also enlarges. So the basic pathway from the urine to outside is blocked by the irregular or symmetrical growth by the prostate, and this causes a difficulty in the patient to pass urine, causing retention in the later stages. So the incidence of BPH is as the age advances above the age of 50, the incidence of BPH symptomatically to the patient increases. And as the incidence increases, they develop clinical symptoms. And after of them, if they are not relieved by medical therapy, which is always tried first, then we have to go for surgical therapy. So how will a patient present himself? The patient will present himself with LUTS, that is lower urinary tract symptoms, which can be either irritative or obstructive. Now, what is irritative symptoms? Irritative symptoms is patient has a lot of frequency, passes urine more than 8 times per day, has to get up at the night, cannot hold urine. Once he feels like passing urine, he has to run to pass urine, a strong desire to pass urine. Sometimes before reaching the toilet, he might leak in his pants and get incontinence before reaching the toilet. That is urge incontinence, urgency incontinence. And a good flow. Also, it may not be continuous flow. It can be an interrupted flow. He has to strain or uh, have used abdominal muscles to pass urine. Or once he goes to the bathroom, then he has to wait and wait and wait till the urine starts. This is hesitancy. Again, this is a type of obstructive symptoms. At the end of the maturation, he feels that at the end, then there is a dribble, terminal dribble, and of after the maturation act, after he wears a pant, there may be some staining of the pant because of the urine. So there are these two factors which in the BPH which affect the that is the size, that is the static component, and the alpha receptor overblock, that is the dynamic component. Now, this leads to various symptoms and syndrome, which is collectively known as lower urinary tract symptoms or syndrome. And uh, the combination of this can cause a variety of presentations in the BPH and the grading of BPH presentation. So it is not a simple disease, and because it is an age-related disease, it progresses with it is going to remain stable or improve. Like you said, so it is a 55% of patients worsen their condition as they age or as the time advances. So what happens in the disease progresses? Again, the worsening of the symptoms, the patient cannot empty his bladder, eventually has residual urine in the bladder, which is makes it prone for urinary infection or urinary stone formation. This subsequently can lead to kidney damage, or he can have an acute retention of urine, cannot pass anything, has a severe pain, and the bladder is full. This needs an urgent intervention on in this case, either by catheterization or by other therapies. The prostate enlargement also has impact on quality of life. The patient is bothered. He cannot go outside because he has to urgency. He has a fear of skinning his pants. He has this fear of asking to go to urine many times. All these things are the bothered symptoms, and that affects his quality of life. So what they don't drink water too much. They pass urine and go. They always find out where the toilet is. So these are all these things that can also be used as a feedback to prevent your symptoms to going wrong. So that is a different issue. Sometimes, because prostate is a sexual organ, like I said, once it gets enlarged, there may be some sexual dysfunction also along with LUTS. And this affects the multiple aspects of health. Sexual problems can lead to mental depression also in the male. So how do you diagnose? One is history. Then there is an international prosthetic symptom score, that is IPSS. You do a digital rectal examination to find out the grade of the size of the prostate clinically. Serum PSA levels if you suspect malignancy. Uroflowmetry, the best method to find out is a simple test where the patient passes urine uh, and you get a graph representing of what pattern he is passing urine. What is IPSS score is a simple question that is related to the irritative and obstructive symptoms, and the patient scores himself. And this scoring can be graded upon mild, moderate, or severe. So out of 35, if the score is less than 7, it is a mild. If it is less than 20, it is moderate. And if it is more than 20, it is a severe IPSS score, and the patient is bothered more. So what is digital examination? It's a clinical examination done by the urologist where he feels the prostate from the rectum, putting a finger in the rectum, and this can tell him about the tenderness of the prostate, size of the prostate. Is there any nodule or cancerous changes occurring in the prostate? Serum PSA is a hormone so-called of the prostate, and it increases when there is prostatic inflammation or cancer. Usually, the serum PSA is less than 4 nanogram per ml. Like I said, this is the uroflowmetry test where the patient passes urine, and you get a graphical representation of the Qmax, that is the maximum flow rate, the time taken, and this. Then you can do a transrectal ultrasound to directly assess the prostate size. This is a better investigation than an abdominal ultrasound for gland evaluation. What is happened? Always medical therapy is first, surgical therapy is always later. However, if the patient has complications of BPH, like he has recurrent urinary infections, presence of bladder stones, acute retention, kidney function is altered, there is hematuria not responding to medicines, then all these indications are that the patient will need a surgery and medicines are not going to help in him. However, medicines are always preferred as the first choice over surgery, and if started in time, 70% of the patients can be avoided by surgery. So, like I said, there are two components in the prostate: the static component and dynamic component, and these two components can be addressed differently by two different medicines. That is, uh, for the static component by 5-alpha reductase inhibitors, and the dynamic component by 5-alpha receptor inhibitors. So alpha inhibitors, that causes the static component, the dynamic of the set get released, reduces the tone of the alpha receptors, hence causing a smooth muscle relaxation, and hence causing a decrease in the spasm at the bladder neck and the prostatic urethra. Alpha blockers can be broad spectrum, or now tamsulosin coming up. It can be super selective alpha 1A receptor blocker also. So with the best tamsulosin alpha blocker super selective trans is to be used is tamsulosin, which comes in the brand name of Jurimax. It comes in doses of zero point 0.4 and zero point 0.2. However, we always start with zero point 0.4 in an adult and give this. Alfizocin is a little broader spectrum alpha 1 receptor blocker. It is not alpha 1A receptor blocker, but it also gives you a better results, and specifically it prevents early retrograde ejaculation more, which is a common feature in the tamsulosin. So in adult actively sexually active male, we always prefer alfusin over Urimax. Okay. So the other medicines which we use are the dutastride or the finasteride. That is a acts on the static component, and because it's a alpha 1 reductase inhibitor, it stops conversion of testosterone to dihydro the active component dihydrotestosterone, and this reduces causes cell apoptosis or cell death of the prostatic tissue, causing a slight decrease in the size of the prostate. Also it decreases the vascularity of the prostate, so it helps during the surgery also if the patient requires surgery later. However, for to add dutastride or finasteride to the drug, you always need a static component. So we always give dutastride to patients whose prostatic size is more than 40 grams. Less than 40 grams, dutastride as a component is not indicated. And you give plain Urimax and do not give Urimax D, which is a combination of dutastride and tamsulosin. So this concludes the basic drugs which we use in BPH. Again, summarizing, it is basically two types of drugs, the alpha blockers and the alpha adrenergic receptor blocker, that is for the dynamic and the static component. Less than 30 grams per ml is indicated for the the both act at a different levels and give a synergistic effect and causes the patient to feel comfortable much better. When all the drug therapy fails, the patient is not having effect, some relief by the drug therapy, then only you consider surgery where endoscopic TURP is considered to be the gold standard of surgery for benign prostatic hypertrophy. So I think this concludes what I'm saying. I would like to have some question answers regarding this topic for BPH. If you have any, then it will be good to answer. Thank you. Any questions, please? Okay. Okay. So there is a question, how long should we prescribe Urimax in patient like diabetic or not diabetic? If the patient requires a medical therapy for his lower uric symptoms, then my policy is I start with Urimax 0.4 milligram and see his effect. If the patient has good effect with Urimax, I usually ask the patient to continue this lifelong. Why lifelong? Because as I said initially, BPH is a aging process. It is not a disease. If you have a disease, you can control the disease by 1 month therapy, 3 month therapy, 1 year therapy. Age you are not going to control. You are going to age more and more and more. So my personal belief is if you start with alpha blocker, you have to continue the alpha blocker and take it. However, it also requires just taking a alpha blocker will not suffice. You need to have a follow up and you have to helping the patient and does he need any additional to go with it or not. Okay, the next question is having a BPH, which patient will be the right choice for surgery? Like I said, surgery is indicated where medical therapy doesn't work or the patient has complications. If the patient doesn't have any complications, if he's fine with medicines, then the only indication of surgery is the patient is fed up with medicines. He says, I don't want to take medicines. I don't want to take so many drugs and please cure me with surgery. Otherwise, surgery as a first line, usually we don't give unless the patient has come with complications which were mentioned earlier. Choice of molecule in the patient with sexually active suffering with BPH, yes, in an el- uh, elderly adult around 40s, 50s, 60s, early for 50s, 60s, the patient may have some sexual demand also. And hence, we can always prescribe alfuzosin initially before we give tamsulosin because alfuzosin, all alpha blockers as such causes some retrograde ejaculation. However, the incidence of retrograde ejaculation is the least with alfusin, and hence we always give alfusin for a sexually adult male. Silofast, again, silodosin is a newer and alpha 1 receptor blocker. The advantage of silofast is that it acts at a faster level. The action of silofast is within 4 hours as compared to 12 to 16 hours of Urimax. That is why for acute retention, sometimes we always start with silofast and then we shift to tamsulosin. So, how long can we give a medic for in old patients? Usually, I give silofast only for a month in the initial period and then shift the patient to tamsulosin because the incidence of postural hypotension is more in silofast than tamsulosin. And hence, in old patients where there is a chance that a patient may fall because of postural hypotension, we always shift from silofast, which we give initially to initiate the treatment, then to tamsulosin Urimax. Prostate size is really described BPH or not? Yeah, yes and no, because usually by transabdominal sonography, which is done normally, they give a generalized prostate size which has a BPH component and also the peripheral zone. Transrectal process ultrasonography will give you a proper size of BPH as compared to the prostate size by the transitional zone which is there in the transrectal examination probe. Otherwise, prostate size is a relative indication of BPH and not a correct description of BPH. Stone in the kidney, stone expulsion therapy. Now that is a controversial thing. However, for lower ureteric stones, not for upper ureteric or mid ureteric stones, for lower ureteric stones which are near the UP junction, because there that is the site where there are alpha receptors. Then you can give alpha receptor blocker, that is Urimax, and try that there is the blockage of the alpha receptor, there is some dilatation of the lower ureter, and that can help in passing of the stone by medical therapy. However, medical therapy doesn't work in mid ureteric or upper ureteric stones. So, for lower ureteric stones, where there is a very close to UV junction, where there are alpha receptors, yes, you can give medical therapy in form of amsulosine, Urimax, and do it. Preferable time to give mirabagram. Mirabagram basically is anti-muscarinic, and it is usually used for overactive bladders. Uh, you can give it any time of the day. There is no specific time which you give it. If the patient has more symptoms during the day, you give it in the morning. If that is what I do. If the patient has more nocturnal symptoms, I'll also give it in the evening and not give it in day. For long treatment is combination of solifenacin and imidacloprid effective. Solifenacin and mirabegron usually we don't give on a long-term basis. Overactive bladder, basically it's a irritative type of a bladder, and hence usually by a 1 to 3 month therapy, the patient usually doesn't require medical therapy, and we can stop the medical therapy by 3 months of things. However, if they need, we can continue for a little longer time, but usually it is not a lifelong process of a combination of solifenacin or mirabegron. It's not to be given as a lifelong process. Okay. Thank you everybody for patient listening. I hope I've cleared your some queries about BPH and lower urinary tract symptoms, and which can help you in your day-to-day life and practice. Thank you very much.